Over the past few decades, it's widely been known that there is a connection between inflammation and cardiovascular disease. It's been documented that inflammation is correlated with the initiation of atherosclerosis and also correlated with the progression of atherosclerosis. And so, for this reason, many medical experts have theorized that any sort of medical intervention that can modulate the inflammatory process in the body may have a significant effect on many health conditions, and that potentially by lowering inflammation, we may be able to reduce the risk for many serious medical problems. For example, many healthcare providers recommend the use of aspirin as a way to reduce the risk for cardiovascular disease. And indeed, a correlation does appear to exist between using aspirin and a reduced risk for myocardial infarction. So a lot of experts have theorized, all right, well, aspirin lowers inflammation, aspirin's lowering cardiovascular disease, so therefore, aspirin works to lower cardiovascular disease by reducing inflammation. And inflammation is the key to reducing these risks for cardiovascular disease. And that very well could be the case. That could be exactly what's going on here. But there's also other possible explanations. Aspirin might be working through other mechanisms other than inflammation. And so this evidence alone doesn't conclusively prove that inflammation is what needs to be addressed in these cases to reduce risk for cardiovascular disease. There's still a lot of open questions. Another line of evidence that does support the role of inflammation in cardiovascular disease comes from research that's done on the compound called C-reactive protein. C-reactive protein is generally considered to be a proxy of inflammation, and researchers found that in patients with ischemia or myocardial infarction, C-reactive protein is elevated. So inflammation is high in these patients. So again, that does support the theory that inflammation could be causing these issues, but there's also other explanations as well. What comes first? Does the elevated inflammation lead to these ischemia and myocardial infarction complications, or does the pathogenesis of the cardiovascular disease lead to an increase in inflammation? It's really hard to tell from these types of studies that currently exist, and we don't necessarily know whether these findings would hold true in healthy populations. And so, it is for these reasons that a team of researchers from Harvard, University of Vermont, and the Brigham and Women's Hospital Department of Medicine decided to work together to try and address some of these unanswered questions and provide evidence to determine how inflammation, aspirin, and cardiovascular disease influence each other. In their study published in the New England Journal of Medicine titled Inflammation, Aspirin, and the Risk of Cardiovascular Disease in Apparently Healthy Men. So the goal of this study was twofold. They were going to randomly assign patients to consume aspirin or to not consume aspirin, and they were going to determine whether or not this had any influence on the risk for cardiovascular events. And they wanted to measure baseline levels of inflammation and use this information to see, all right, can we predict the effectiveness of the intervention based off of baseline inflammation levels? So at the onset of the study, the initial hypothesis put forth by the researchers was that aspirin consumption is going to decrease the risk for cardiovascular events in patients who have elevated inflammation at baseline, but it will not have any beneficial effects on patients who have low levels of inflammation or normal levels of inflammation at baseline. And thus, they are hypothesizing that the mechanism of aspirin that causes a reduction in cardiovascular disease is, in fact, by reducing inflammation. That was their initial hypothesis. So, in order to perform this study, the researchers drew on data that had been previously collected during the physician's health study. So this population consisted of male physicians that were between the ages of 40 to 84. The study initially involved a 16-week run-in period. And during that 16-week run-in period, that's when samples of the blood were collected to determine inflammation levels. So the physicians provided their blood, and the researchers looked to determine what the quantity of C-reactive protein was present in the blood so they could determine if these physicians were in an inflamed state. And after that, they essentially followed them for 14 years and wanted to see, all right, what's going to happen during this time period. In the intervention group, the subjects were given 325 milligrams of aspirin on alternating days. Then in the control group, the subjects were explicitly told, don't take any aspirin. And the intervention group consisted of 543 subjects, and then they were matched to a control group also of 543 subjects, so that the intervention could be compared to a similar population with equivalent demographics, but simply wasn't taking aspirin. The purpose of the study was to evaluate what the effects of the aspirin were on cardiovascular events. So how did they define cardiovascular events? Well, first of all, they were looking at either myocardial infarction, stroke, DVT, or pulmonary embolism. For myocardial infarction, it was defined by elevated plasma concentration of troponins or changes that were evident via electrocardiographic assessment. So they did not count silent myocardial infarctions as part of this event. For stroke, they defined a stroke by sudden onset neurodeficits that lasted for at least 24 hours. If it was very transient, less than 24 hours, it was excluded as an event. DVT was defined using either venography or an ultrasound, and then a pulmonary embolism was defined by either angiogram or ventilated perfusion scan. And so all of these events were individually tracked to determine, was the group that was receiving aspirin having different quantity of events compared to the group that wasn't receiving aspirin. After 14 years of the study, when the researchers finally had a chance to examine the results, the findings were pretty amazing. When they looked at the risk for cardiovascular events and compared that to the baseline of inflammation levels, there was a very, very strong correlation. So what these researchers did was they broke it up into quartiles, and they looked at how does the risk for cardiovascular event in the highest quartile of inflammation compare to the risk in the lowest quartile. And the results are pretty shocking. So the patients who had the highest level of baseline inflammation were 3 times more likely to ultimately go on to have a myocardial infarction compared to the patients who were in the lowest quartile for inflammation. And as for stroke, the patients who had the highest C-reactive protein at the baseline level were twice as likely to go on to have a stroke over the next 14 years compared to the patients who had the lowest C-reactive protein. So this was a very strong correlation. And this really contributes a lot to the research world, because one of the questions they wanted to answer was, do cardiovascular events lead to increases in inflammatory compounds, or does the increase in inflammatory compounds precede the myocardial vascular events? And this shows strong evidence that these patients had elevated inflammation many, many years before they ever actually experienced any cardiovascular event, contributing to evidence that inflammation does play a causal role. Something that was very interesting, though, in the results was that when the researchers looked at the risk for venous thrombosis for patients in the highest quartile of inflammation, there was not a statistically significant difference between the highest quartile versus the lowest quartile. So this study also provided evidence that unlike myocardial infarction and stroke, venous thrombosis may not be directly influenced by inflammation in the same way. Another fascinating finding that was found once the researchers analyzed the results was that these correlations between baseline inflammation and the risk for myocardiovascular event were independent of baseline lipid profiles, which is very important because many times medical professionals can become tunnel visioned on just LDL, HDL, and not consider other factors. And some may argue that elevated inflammation is simply a proxy for dyslipidemia. And by addressing the dyslipidemia, the inflammation will go away. But the research does not support that theory in this particular study. This research found that regardless of what your HDL and LDL are, regardless of the triglycerides, whether they're high or low at baseline, that does not change the fact that inflammation, defined by C-reactive protein, is an independent risk factor for heart disease. So all of the results that I have discussed so far were evident in the subjects who were consuming aspirin and were also found in the subjects that had not been consuming aspirin. When the researchers wanted to compare between the two groups, the results were pretty fascinating. It turns out that in the patients who had the highest levels of C-reactive protein at baseline, the aspirin was extremely effective at reducing the risk for myocardial infarction. But in the patients who were in the lowest quartile for inflammation at baseline, the aspirin was not statistically significantly better than the control group. So one of the questions that the researchers set out to answer at the beginning of this study was, does aspirin work by reducing inflammation? And these findings support the hypothesis that says yes, the aspirin was only effective and only beneficial in the patients who had high levels of inflammation. So this shows that aspirin can be effective by affecting inflammation, and that yes, this does provide support for the theory that inflammation isn't just simply correlated with cardiovascular disease, it has a very causal role in the process, and that by influencing inflammation, we can influence the progression of cardiovascular disease. So there were two limitations that the authors discussed that may have influenced the results. The first one was that inflammation was determined by only one single baseline blood sample. And so it is possible that just taking one sample may not have been fully representative of the patient's normal state. For example, if they were having an acute rise in inflammation, they may have been classified as a high inflammation patient, but maybe that wasn't normally the state they were in. So if more measurements have been taken to assess inflammation, that may have increased the validity of these results. A second limitation that the authors briefly mentioned was there's always a possibility of some sort of laboratory error when taking blood sample estimates. However, they did mention that there's no reason to suspect that the laboratory error would go in any particular direction or would bias the results in one way or another, that if there is a laboratory error suggesting more inflammation, it would get canceled out by other laboratory errors suggesting less inflammation. So they didn't really feel like this particular issue would have been a major limitation. It wouldn't be expected to have a very strong influence on the findings. So the authors provided a few explanations for the results they're finding. First, the fact that there was no correlation between baseline inflammation and the risk for venous thromboembolism might be explained by simply that the relationship between inflammation and vascular compromise might just be limited to arterial circulation. Inflammation might not be having the same effects in the venous system. Unlike the risk of venous thromboembolism, the risks for myocardial infarction or for ischemic stroke were correlated with elevated CRP at baseline. And the authors provided a few possible explanations for this. They suggested CRP could be a surrogate for elevated interleukin 6, as interleukin 6 has previously been demonstrated in other studies to influence macrophage and monocyte recruitment in atherosclerotic plaque. Or they also suggested that CRP may be a surrogate for monocyte-induced tissue factor expression, which has been previously shown in other research to initiate coagulation. So if patients with elevated CRP also have higher interleukin 6 and monocyte-induced tissue factor expression, this could explain the direct causal mechanism why elevated CRP will later lead to an increased risk for these cardiovascular events. In many ways, the initial hypothesis that had been formulated by the researchers was supported by the findings of the study. The researchers did find that baseline inflammation levels, as determined by C-reactive protein, was able to predict the risk for myocardial infarction and ischemic stroke. Furthermore, this was an independent risk factor even after other risk factors such as HDL, LDL, and other forms of dyslipidemia were controlled for. And one of the questions the researchers wanted to answer was, does cardiovascular disease lead to an increase in inflammation, or does inflammation precede cardiovascular events? And they found that in this study, the inflammation was present many years before the cardiovascular events came up. The one area of their initial hypothesis that was not confirmed was they had originally hypothesized that inflammation would increase the risk for venous thrombosis, and that was not supported by the data. The patients with the high baseline inflammation did not go on to experience more incidences of venous thrombosis compared to the other patients. So some of the key takeaways from this study were that yes, aspirin can reduce the risk of heart disease, and the benefits of aspirin appear to be directly modulated by its effects on inflammation. It only worked in the patients who had high inflammation, didn't work in the patients who had low inflammation, so it appears that aspirin does work primarily through its effect on inflammation. However, the key takeaway for the study for me, and the reason that I thought the study was so amazing, was that the researchers didn't simply ask, does aspirin work or does it not work? Instead, they took it a whole step further and asked, in which patients does aspirin work? And in which patients does it not work? They looked at the responders and the non-responders, and they asked what makes these two groups different, and how could we predict which patients will be responders and which patients will not. And this is exactly the type of research that healthcare providers can benefit so much from, because healthcare providers can't simply use a one-size-fits-all approach with every single patient. Every patient is different. Every patient is going to have unique needs. And so providers need some sort of way to be able to look at the patient's baseline characteristics and be able to predict which interventions they're going to respond well to and which they aren't. And so research like this is the key to that. And research like this is exactly what the healthcare field really needs right now. And these types of studies can really pave the way towards predictive, personalized medicine so that patients can get better results, can get the treatments that are best for them, and ultimately have healthier and happier lives.